Okay, why don't we go ahead and get started? I'm sure that there'll be a few more people joining us. Thank you for coming to our enrichment program for the Center for Improving Palliative Care. I'm very, very excited today to introduce Dr. Jean Kutner. She's an experienced physician executive with a very successful track record in academic health systems and national leadership. She's a wonderful person. I had the pleasure of meeting her at a study section a few years ago. She is currently the Chief Medical Officer at UC Health, University of Colorado Hospital, and a professor of medicine in the Division of General Internal Medicine at the University of Colorado School of Medicine. Prior to becoming the CMO, she served as the Chief of General Internal Medicine at the University of Colorado School of Medicine for 12 years. She's board certified in internal medicine, geriatric medicine, and hospice and palliative medicine. And her research and clinical interest focuses in the care of people with serious illness and their caregivers. She has a very successful track record for funding as principal investigator, including being the principal investigator on the Palliative Care Research Collaborative. And she's published widely, is very wise, and we're very lucky to have her. So thank you, Dr. Kutner. Please start.
Well, thank you, Pat. Thank you for that lovely introduction. And thank you all for making some time in your calendar to spend some time together today. I will start with an apology and thank you for your flexibility. I know we were originally scheduled a few weeks ago and we had a joint commission show up for our triennial visit at the hospital, and I got pulled into all of those fun activities. So I really appreciate everybody's flexibility and look forward to spending some time with you. This session will be a little bit of a mixture of kind of my personal story and sort of what's been some of my driving sort of forces along the way and how those have played out. And then a little bit around some thoughts about setting your own sort of personal vision or program vision or whatever it is that you're trying to accomplish, and then a bit about why doing the things that you are doing set you up well to be leaders and to be change agents. So kind of a little mix of a variety of different topics that are really all about the career journey. And people often ask me, did you set out to do what you're doing now? And I kind of always say that if I were applying for a job with you, I could tell you a very compelling story about how everything that I've done along the way was perfectly planned out to prepare me well for whatever position it was that I was applying for with you. Because I could string together, and I'll show you a little bit of what I've done along the way and make it sound very purposeful. And I will also say, well, it's been driven by a vision of what I wanted to accomplish. The how I've gotten there has been a little bit more related to sort of being open to possibilities rather than being directly sequential. So feel free to ask questions about that as well. So I'm a firm believer really in everything that I do, but especially in what we do as individuals and as we think about our own career trajectories, is to always start with the why. Why is it that I'm doing what I'm doing? Why have I pursued a career in academia to enhance care for people with serious illness, and being thoughtful about what is your own why, what is driving you to do the work that you are doing. And I would say for me, it's a combination of clinical experiences, and this really dates way back to when I was in medical school. I did med school in San Francisco. And from early on in clinical experiences, really, seeing people with serious illness and the extent to which they were suffering and their families were suffering. And that's really what really inspired me to do palliative care, even though palliative care wasn't a specialty at the time, but to focus my training and my academic and my professional work on enhancing care for people with serious illness. And it's still the why that drives me. I go on service for our palliative care clinical service tomorrow, and I always find that so inspiring for reminding me why I do what I do from a research perspective, from a clinical perspective, from a teaching perspective, and with my administrative hat on, that it's all about the patients and improving their lives. And then there's also the personal side of things, and we often all have a personal story on what drives what we do. And this is actually my mom, who died of Parkinson's disease back in 2014. And I happened to be, at the time, her last year or so of life was on the Institute of Medicine panel that came out with the Dying in America report. And I had such cognitive dissonance, honestly, during that year, because here we were writing this Dying in America report and putting out these recommendations for what care for people with serious illness and near the end of life should look like. And at the same time, trying to coordinate that care for my own mother, and realizing that the only way that we were able to make sure that she wasn't in the hospital for the last 3 years of her life and was able to be at home and to spend time at home was because she had a husband who was a devoted caregiver, was a retired surgeon. They had the means to be able to hire in caregivers, and she had a palliative care daughter who was able to coordinate home palliative care services and then home hospice services for her. And just this sense of, you shouldn't have to have a palliative care daughter to be able to get that sort of experience. So those clinical experiences and that personal experience really continues to drive what I do. And just be thoughtful for yourself about what drives what you do. Now there's an overall imperative for palliative care research, and those of you that are palliative care researchers, this is not news, but you know that we even though things have gotten so much better over time, there still is a need for better quality of care for people with serious and advanced illnesses. And that even again, since things have gotten much better, we still have people that have inadequately treated physical distress, fragmented care systems, poor communication, untreated psychosocial issues, as well as real strains on people's family caregivers. So we've gotten better, but there's still plenty to do along these ways. And the evidence base has gotten much better. I mean, when I started in this, I was a fellow. I came here to Colorado as a fellow in, I'm going to age myself, but 1994. And I was a research fellow, and I wanted to get clinical experience and to learn how to have better clinical care of people with serious illness. What did I do? I served as a medical director at one of our local hospices and learned from the hospice nurses who said, well, we do this because this is what we do. And I think we have, it was a great education. And the evidence base has greatly improved. That said, I mean, those of you that are clinical, think to the clinical work that you do and say, how much of what I do clinically in palliative care really has a strong evidence base behind it. It's gotten better, but there's still plenty of opportunity. And we also, while again, it's gotten much, much, much better, we still need a better pipeline of investigators coming through, as well as research centers like what you all have put together there. And it's gotten better, but plenty of opportunity. And this is just a compilation of some of the urgent needs in palliative care research that were put together by some national groups. When I started in the field, we were really only doing observational studies, and it's so exciting to seeing that we're now doing many more randomized trials, longitudinal studies, efficacy, and even now getting to pragmatic trials and dissemination and implementation. So we are improving as a field, And I'll just say it again, there's plenty of opportunity for all of you out there. I'm not going to read through all the bullets on this slide because I know you guys can all read. No. So that is sort of the why that has driven my why is I've never wanted to be a researcher who just does research where the research sits on the shelf. Or, I used to joke, only my mom reads it because I send her the article. I wanted to be able to do research that really affected the care of people with serious illness. So kind of the what's, there's a number of things that I've done along the way, and this is not meant as a brag slide. This is meant as sort of just thinking about the different ways that you can have impact when you know what you're trying to do. So this is the areas where my own research has focused, and I kind of put this in the evidence generation bucket of the places where I focused my research. And you'll note that it's a little diverse and diffuse, and that's always an issue of how you design your own research career. Do you focus on really one narrower area and really dig deep, which is a perfectly valid way to establish a research career, or do you have more of a broad focus? And for me, that was the way I went, was more broad, but always focused on studies that improved care for people with serious illness. So no one right way to do it, but understanding what your research trajectory is and making sure that that's well planned out. I've also been very committed to building research infrastructure, and I'll go a little bit more into that, particularly with the PCRC that Pat mentioned. I started out with POPCORN, which was the Population-Based Palliative Care Research Network, which built on the model of the family medicine practice-based research networks. And it was mostly to be able to do research with hospices. And then the PCRC, I'll get into a little bit more. We've been down the PCRC journey for the past about 11 years. And then I'm very committed to mentoring and a research pipeline, and have used a few different NIH structures to advance our research pipeline, both here at the University of Colorado, starting with the K07, and now have a postdoctoral T32 with a real focus on building that next generation of investigators. And then I'll never wanting to do research that just sits on the shelf, making sure that the research that we're doing gets out there and also looks at policy. And then had the pleasure of starting our palliative care research, our palliative care consult service here at the University of Colorado, and even the greater pleasure of then passing it off to somebody else who's a much more effective director of the clinical program than I ever was. And then there's always opportunities for both local and national leadership as well. So I just want to give you a little bit about the PCRC. I know that many of you know about it already, but for those of you that don't or need a refresher, give you this little update here. So the PCRC has been funded by the National Institute of Nursing Research, or NINR, since 2010. This is our structure. I share leadership of it with Catherine Pollock at Duke and Christine Ritchie at not at UCSF anymore. She's now at Mass General. And then what our overall goal is to provide resources to you as the research community to help you do your research. And this is when people ask, what do I do now for my research? Most of my research time right now is focused on the PCRC and the T32. So helping others do research, conducting a little bit of my own, but mostly helping others do research at this point. This, as I mentioned, is our executive committee, myself, Drs. Ritchie and Dr. Pollock. And then here's our steering committee, which is quite diverse. We've got PhDs, we've got nurse scientists, we've got social scientists, statisticians, and a focus on pediatrics as well to help us do the work. And then what the PCRC really offers to investigators are these resource cores that are available to you as investigators, and the information is available through the PCRC website, to be able to not all of us keep reinventing the wheel. The whole idea is to be able to have resources available to you as investigators. And this is our team here. Kind of reflects palliative care research, so we got one guy and the rest women. You know, we're good with women leadership. This is where we are as part of the PCRC. We have just over 560 members as of March. And here's where our members are located across the country. So what PCRC does is also gives you access, those of you that are interested in multi-site studies. We can certainly help connect you with investigators across the country. And I mentioned the website. Like I said, this talk's not fully about the PCRC, so I'm not going to go much more into detail here, but definitely feel free to visit us on our website. And if anybody has questions afterward, just reach out to me about the PCRC. Because this is really more about kind of the journeys. One of the resources the PCRC does offer, which may be relevant to those of you that are either pre or postdocs, is we do have two now de-identified data repositories that are available for researchers who are interested in doing secondary data analysis. There's one that's all quantitative data, and then we just launched our qualitative data repository and have the first person doing a secondary data analysis on those data. So very excited to now have that available. We also have some special interest groups that are listed here for those of you that are looking for people who are interested in similar topics as you are. And if anybody's interested in getting connected to any of these special interest groups, either reach out to me or you can indicate that on the website. Okay, so that was so what have I done so far? The why, which is it's all about patients and their families. The what, multiple ways at addressing those things. And then there's the how. And I would say for me, one of the key hows has been just amazing mentorship that I've had along the way. The individuals that you see in these pictures, the top left is John Steiner, who was my fellowship director when I first came to Colorado to do a research fellowship. And I think he kind of took a flyer on me because there was nobody here at University of Colorado at the time doing palliative care research, but he said, you're interested in developing as a researcher, I will mentor you as an investigator and we will find content mentors for you. And he was just really got me started in my research career. The gentleman in the white coat is Dennis Janigan, who was the head of geriatrics here at University of Colorado. And I met him when I was a fellow, and he said, you really should do a geriatrics fellowship. And I said, really, why? And he said, because one, as a developing investigator, you need another year of fellowship before you're ready for faculty. And two, because geriatrics is going to be the field of the future. He couldn't have been more right on that. And he really helped me get started in my career. And then at the bottom is Bob Anderson, who was my division head for my first faculty job. And I would count him as both a mentor and a sponsor, in that he really started me on my leadership journey as well. He said, are you interested in academic leadership? And I said, I'm not sure. And he said, well, I'm going to have you shadow me and learn, and I'm going to start getting you on committees so that you get to learn. So to have that strong mentorship and sponsorship, especially early in my career, was definitely essential. And then, of course, there's funding, and this is just a smattering of where I've had funding from over the time. And I think looking far and wide and diversifying your funding. And then, so what have I said? That the the how, mentorship, funding, and then collaborators. I think finding people that you really like to work with and have a shared vision, it makes this work really fun. On the left is Dave Nowles, with whom I started Popcorn back in many, many years ago. He's a family physician, hospice palliative medicine doc, and we both had a similar vision for involving hospices in research. And Dave and I remain very close colleagues on our palliative care team. In the middle is Marlene Smith, with whom I wrote my first R01. Marlene is a College of Nursing. She was here at Colorado, and she's in Florida, at Florida Atlantic. And we wrote our first R01 together, did our first randomized trial together, and just was a pleasure to work with. And then at the top is Amy Abernathy, with whom I started the PCRC, and which really started honestly as a conversation of, hey, you think we should do this? You think the field is ready? And to have a collaborator that you enjoy working with, enjoy writing with, can go through ups and downs with, is just amazing. And then on the right, as you met before, is Christine Ritchie and Kath Pollock, and the three of us have the pleasure of co-leading the PCRC. And we spend so much time with each other virtually that our partners can recognize each other's voices. Oh, sounds like you're talking to. So I encourage you all to find wonderful collaborators with whom you enjoy spending time. So that's the sort of my journey piece of it. And I think, the rest of it will be more about, thinking about ways for you to channel your own passion to make a difference. And whether that's difference through research, clinical programs, through policy, however you find your home, but taking that passion and making a difference with it. I think a key first thing, and this is something that I work with my mentees on, is to develop a vision statement for yourself, a personal vision statement that says, why is it that you do what you do? And to take this quote from Lewis Carroll, you need to know where you're going. Otherwise, any road will take you there, because it doesn't matter where you go. So developing that vision statement, and what that should do is describe the future. What is it? Where are you going? What is it that you want to do? And it should be, if it's a personal vision statement, and it should inspire you. A personal vision statement is really just for you. It's a way for you to say, this is why I'm doing what I'm doing. And it's also a way for you to then sort of reality check. If somebody's asking you to do something, does it really comport with your personal vision statement? So, or if it's an external vision statement, it should inspire others, and it should also create that commitment. And that's why I have this quote here from Jack Welch, that we need to create that vision, articulate it, own it, and then do that, whether it's for yourself, for your program, for your institution, at whatever level you want that vision to be. And then also develop a mission. What's my strategy? How am I going to achieve that vision? That's how you should think about a mission. What do I do? How do I do it? For whom do I do it? Those are the components that go into a mission. So I'm going to give you some examples. These are actually from some of my mentees. These are personal mission statements. I did have permission to share these, and you'll see that they're all a little bit different. They are personal, and they drive what these individuals do. So I'll just give you a moment to read this first example. And here's another example. This is also from one of my mentees of a personal mission statement. So hopefully those give you a sense of, if you're to go about writing your own personal mission statements, the types of things that you might consider. These are mission statements from our palliative care consult service here at University of Colorado Hospital, and we actually begin every one of our monthly business meetings of our team by reviewing these vision and mission statements, because it really grounds us to remind us what are we about and why do we do the work that we do. And we found it to be very helpful to keep us focused. And then this is our vision statement for the Palliative Care Research Cooperative Group, or PCRC. This was something that we wrote back in 2010 when we were starting up the PCRC, and we revised it a few years ago, but it has really been helpful to remind us what is it that we are about as an organization. Why do we exist? Why do we do what we do? And then you'll see in the PCRC mission statement, this is the how we do it. These are the things that we do. And again, it brings us back to what is our focus as an organization. So that's going to be my first, hopefully, takeaway, is to think about what is your personal vision and mission, or what is it of your program, whether it's your research group, a clinical group, whatever it is that you do. Then I'm going to talk a little bit now about affecting change. And we all work in really not even complicated environments, but complex environments, and being thoughtful about how we affect change. And this can be at multiple levels. This can be within your group. It can be within your division, department, your institution. It also can be helpful as you're trying to put into place new programs. So just some thoughts on steps to actually making effective change in our environments. And this is relevant, I think, across the board, whether people have a official leadership title, or they're just trying to make change. And one of the things we've sort of joke about here is that sort of just do it, make the change, and then sometimes you have to get permission later. It's actually how we got our palliative care service started here at University of Colorado back in 98 to 2000. Is basically we just did it. We identified a problem. We said, what's the relevant ecology? What's going on here? What are the issues that we can help, that can help our institution? What is a win and a loss for both you as well as the leadership of your organization? And then find ways to align whatever it is that you're trying to achieve with what's happening locally. Is there an issue locally that you can help people with? This is also a way to sell your research. If those of you that work in research in community-based settings, figuring out how what your research question is fits with what is going on with that organization, what their pain points are, what their staff need, et cetera, to finding ways to create that win-win situation where what it is that you're trying to accomplish fits well with whatever that setting is where you're trying to accomplish it. And these are just some questions to think about as you're trying to understand that local context. And like I said, this can apply to, I'm trying to, this thinking early on in my career, I'm trying to convince a hospice that has never done research to participate with me in research. I needed to understand what was happening at that hospice, what were their pain and pressure points. Maybe this initiative that I'm doing as research can help them solve some of those issues. Like we would look at, does their staff need continuing education? Did they need to do some quality improvement? Maybe we can do quality improvement along with the research. So thinking about what are those things that are happening locally, contextually, with whatever it is that you're trying to effect something new that can help you then frame what you're doing that in a way that's relevant to that context. We kind of tend to, I think in academics, think about sort of our own narrow world, and sort of seeking first to understand is probably one way to think about it. And then thinking about the message. Who are the stakeholders? Who are you trying to sell whatever it is you're trying to sell to? And I have it's been a while, a talk that I gave here locally on campus that basically it was two researchers and it was talking about how they were actually, their life was in sales, What your job as a researcher is to sell, whether you are selling your research idea to study section, or you're selling your research idea to other funders, to maybe to your dissertation committee, to the context where you're having your research. So identify, who do I need to be, quote, selling this idea to, and how do I need to shape my message? I'm not talking about lying, but how do I shape my message in such a way that it resonates with those key stakeholders? Because it may be a different way of framing your message depending on who it is that you're talking to. And then being really clear about what it is, how you will achieve it, and what those deliverables will be. And this whole idea of an insider review is so helpful, to have somebody who's either been where you're trying to go, or who has been in a decision-making setting, to look at what you're planning on sharing with the actual decision makers and getting some feedback. One example of that, with actually my CMO hat on, is I will often take, if there's something I need to sell to or explain to our system CEO, I will often go to our system CMO, who has worked with this person for many years, and say, okay, listen to this as if you were my system CEO. Tell me how she's going to respond to it, so that I can shape my message to better fit what she is most likely to hear. So, we often think, oh my gosh, I would say academic medical centers or academic health centers is probably one of the most complex environments. My goodness. You think about all the different interacting elements. You've got the schools, you've got the clinical settings, you have the multiple professional schools, and that's within the broader environment of healthcare, not to mention the community-based environment of healthcare. And you wonder why it feels like sometimes it's hard to make change. I think the last year has shown us even more that our environment is even more complex than we thought. If we didn't think that, or if we thought that life was ambiguous and uncertain prior to the last year, I think we have really seen that over the last year, of how we need to learn how to function in a setting where information is ambiguous or it changes so often, and figuring out how do we still keep moving forward with those things that are important to us, and moving forward that message and that mission, and recognizing that things are going to continue to change. Actually, right before I got on with you all, I was on the Zoom call with our head of hospital medicine about a new initiative that she wants to move forward. And we had the discussion about, this is going to request new resources, new FTE, probably not the right time to be asking for new resources and new FTE right now, given where medicine is. That said, I think it's important. Let's lay out a plan to set the groundwork now and start toward a hope that we can get this funded by 2 years from now. And it's much, we always think, in healthcare, we're fixers. So we want to just make it happen. We know it's the right thing to do. And sometimes we just have to really sense that environment and say, now is not the right time to push on this. Maybe it's time to focus over here. So I will wrap up with an argument that because we're in palliative care, we actually should totally thrive in this kind of environment. And I actually think that more people in palliative care should be in leadership roles because of this. So for those of you that are clinical, you think about, what do we do in palliative care, right? We meet with the family, and often there are, differences of opinion. What do? We first set out to say, what are the common goals? Let's identify what is the goal here, and then we will make a treatment plan that is consistent with the patient's goals and values. We're totally comfortable with that from a clinical perspective. If I'm coming into more of an administrative setting, it's really the same thing. You never want to go in first with your tactics. You want to say, what is it that we are jointly trying to achieve? And then let's jointly identify those strategy and tactics to achieve that. We know in palliative care that we modify the treatment plan often as the patient situation evolves. And that is often necessary in a complex environment as well. As the situation evolves, as we learn more, we then need to modify how we're approaching that. We often joke in palliative care that communication is our procedure, right? It's what we excel at. And oh boy, in a complex environment, communication. I sometimes joke when people ask me, well, what do you do as the chief medical officer? And I say, well, actually, I'm a cultural navigator, so that when the faculty are saying this, then I will translate it to my C-suite colleagues. Well, the faculty are saying this, what they really mean in your language is this. And the same thing, my C-suite colleagues say something and I'll turn to the faculty and say, when they're saying this, what they really mean in your language is this. And we all have the same goal, but we just look at it from different perspectives. Palliative care cares for patients across the care continuum and across all care settings. And boy, that is definitely a hot topic these days in healthcare. And those of you that know about the continuum of care, it's a really highly sought after skill these days. And in palliative care, we navigate conflict. We do that all the time. And that happens a little bit on the administrative side as well. And I have actually been known to say with my administrative hat on, okay, just a minute here. Is somebody actually dying? Okay, no, can we take a deep breath? And let's then navigate through this to a way that gets us to a common goal. And we apply evidence, and in my administrative role, it's so important to utilize data to inform our decision making. There is often no one right answer in either of these worlds. So maybe in the question and answer time, you can tell me whether you think this is a crazy sort of analogy, but I'm going to give you a little bit of more specifics. So if you think about in the red on here, or the top bullet is going to be what we do in palliative care all the time. And then in the black, or the sub bullet, is some of the things that have been written about being successful as a change agent in complex situations. So goals of care discussions equals creating a shared purpose. Working in transdisciplinary team-based models that we do in palliative care fits well as creating this culture of inquiry and learning and experimentation and accepting in divergent thoughts. Communication, care coordination, and our seek first to understand approach in palliative care helps with this connectedness, or you'll hear about sense making. And our idea, we do this in palliative care a lot, of either time-limited trials or quality improvement. We do a lot in palliative care. And from an administrative perspective, looking at rapid loops for feedback. I tried this. Is it solving the problem? If not, let's try something else. And we often in palliative care, we kind of live in that ambiguity space. So we should be really comfortable with it when there's ambiguity in our other settings as well. And our focus, as I mentioned, on matching our care plan to patient goals and values, and our ability to shape palliative care to meet organizational needs. We saw a lot of this through the COVID surges, where palliative care was really called upon to meet some significant organizational needs. This also equates to creating those shared values and shared purpose as well. And in palliative care, we're also used to defining what is and is not possible, and identifying what are absolutes and what are not. And this also translates over to saying, what are those sort of hard stops? This has to happen, and where can we be flexible? So I will end with this thought that our role as palliative care experts are to help patients and families make a sense of what's going on, And our role when we're trying to affect change is also to help our teams make sense of what is going on around them. And especially in our even more ambiguous world these days, I really think that we as palliative care experts have a unique skill set that can be really helpful in our ambiguous and complex world. So charge to you is, what will you do next? I know there's lots of things to change. Are you going to change it through evidence generation, through creating new programs, through policy? You guys all can be change agents. And I want you to think about how you can take that why that is driving you and truly achieve a different future. So I'm going to end there. And I think I left. Yes, good. Time for questions. So I'm going to, I'll leave this on a sec for if anybody wants to reach out. This is my email address, and then this is our PCRC web address. And I'm going to stop sharing so then I can see you all. And I'm happy to answer questions or hopefully foster some discussion.
Thank you so much, Jean. I absolutely loved it, and I hope we do have some great discussion. I really thought myself, the why, what, how, and the idea of making a personal vision and mission for everyone, no matter where we are. I mean, that's really good advice. It's really good advice. Does everyone have some questions for Jean? Quiet group.
I have a question. Thank you, Dr. Kutner. That presentation was wonderful, and it was really nice to see your journey from where you began and where you are now. I also wanted to thank you. I used the data from your statin discontinuation trial for my dissertation, and I've never actually thanked you. So I just wanted to take the opportunity to do that. I have a question about the urgent needs in palliative care research that you identified and listed in your presentation. One of the questions I have is related to identifying valid and reliable outcome measures for palliative care studies. I'm currently in the process of writing my K, and that's something for my intervention piece that I'm still kind of struggling with. And I was wondering if you could speak to that a little bit more.
Yeah, absolutely. So one will be a little bit of a pitch, and that's to utilize the PCRC measurement core. So if you go to the palliative care research.org website and go to the measurement core, we do have a measurement library on there. There's actually two measurement libraries. One's on the measurement core part of the website. And for those of you that are interested in caregiver research, the caregiver research core that's co-led by Betty Farrell and Nick Dion-Odom has caregiver measures. So one would be to absolutely use those resources, and also both the measurement core co-leads, who are Antonia Bennett and Laura Hansen, both at UNC, are happy to do consultations. That's what the funding from the NINR supports us to be able to help investigators with and do consultations. And I myself have, for when I've been writing grants, I reach out to Antonia and Laura and say, here's my research question. Help me pick the best metrics. So my first would be to use that as an existing resource, because that's why it's there. Don't reinvent the wheel. And the measurement library is downloadable. Okay. The second would be, I think, and you'll hear this if you talk to Antonia and Laura, as well as be really crystal clear on what questions you're trying to answer. Because I think you can sort of spin yourself in circles when you don't have really crystal clarity on what the questions you're trying to answer. And then especially if it's like an intervention study, being really clear on what outcome do you actually expect your intervention to impact change. I think we get ourselves in trouble when we have a mismatch between our research question or our intervention and the outcome on which you would reasonably expect to have change. And then there's also the realization that since there's still plenty of need for development in this field, there may or may not actually be an existing validated metric for what you're looking for. But I would say, and I swear all of us investigators have gone down this path, well, I'll just develop one. But recognizing that as a whole other field of study, developing valid and reliable measures. And I would think probably think twice, thrice, quattro, or whatever, before you go down the path of developing your own metric. Because that, I think, especially as a junior investigator, unless that's really what you want to be a psychometrician, I think that can also detract from your sort of research development. So I would search high and low for something that's already out there and validated before you go down that path, would be my sort of mentor advice.
Thank you.
Other questions? A couple of things that I thought. We have some clinicians, expert clinicians, Carol and Penny, or some of them, there might be other ones. And I'm just going to make that connection between leadership and palliative care, because that was really great, and shows that you could, the skills that are needed in both and how to navigate it. I also want to introduce Robin. Robin, she's somebody I just met out of Connecticut who is very interested in spirituality and in pediatrics, but just generally spirituality and palliative care. And Robin, I don't know if you have any questions or want to say anything.
No, I'm just taking it all in and really enjoying what Jean has to say. Thank you so much.
Thank you, Robin.
Thanks. Other questions? Harold or Bevan, did anybody have any other questions or thoughts?
Pat, I have a question. Sorry, Danielle, go ahead.
Thanks. Hi, Jean. Thank you so much for speaking.
Hey,
I just want to say that I'd say the PCRC is probably 40% of the reason I'm a palliative care researcher. And so it's really helped me get to where I am now as a faculty member at NYU. I have a question about, we have palliative care. We're learning in the field as a specialty field. It's growing. It's being employed more often in the hospital. And then as nurses, a lot of times our eyes look out into the community. I'm doing work in an under-resourced assisted living facility in the Bronx, and they have no resources. And just trying to introduce palliative care to a palliative care naive setting where the need is high, do you have any tips on how to sort of promote palliative care in that setting? And how might I connect it to a more researched academic environment that's willing to share their wealth of resources?
Mm-hmm. Yeah, I think it really is sort of that palliative care principle of seek first to understand, and understand from their perspective, what is it that they're seeing, where is it that they see that they have needs, or their population has needs, what are their pressure points, because healthcare being the messy field that it is, and then especially with assisted living facilities sort of being in this sort of no person's land where they're not really healthcare and not really social services either. But I really think first trying to understand, you can go in and say, oh my God, look, this whole population needs palliative care. It's crystal clear to you, right? But I think really trying to understand from their perspective, what is it that they struggle with, and also going in with really a true open mind of your vision of what they may need for palliative care may or may not actually fit with their need, and then it may need to be an evolution over time as well. Sometimes I've seen things that have resonated, like the staff themselves need, are asking for upskilling in particular things. So, we as academics, it's easy for us to provide, continuing education. That's an easy. Maybe it's, they need an easy button helpline for, what happens when Mrs. Smith is doing X, Y, Z, how can we help them. So thinking about things that really meet some need that they have, especially something that's, quite relatively easy for us to do from an academic perspective, that is really insurmountable. What do we do? What did I do for a while with community-based hospices? Things that we take for granted, access to a medical library to do a lit search, to find, evidence on something. We do that in our sleep, basically, whereas most community settings do not have the great access that we do. So I've done I would do lit reviews for the hospices who participated in our studies, or help them with a QI initiative that, again, we can do in our sleep because we live doing that, but that can feel really insurmountable for them, or a little data analysis, those sort of things that for us are second nature. Just some ideas.
Thank you. Those are great.
And figure out how to turn it into scholarly product. Oh, and also, the people don't often take me up on it, but then I would, if you are turning it into scholarly product, make sure you offer to them to be as part of that scholarly product. I've done early on in my career, I actually did a lot of co-presentation with hospice folks who were not academic at all, but at national meetings, I would invite them to present with me.
What a great idea. Jing, you had a question?
Yes. Thank you, Jean, again for this wonderful presentation. And in your presentation, you mentioned one of aspect need to the future research or clinical is the community, the palliative care. So that is Kamal and I conduct a pilot study. We are trying to develop a tool to assess the home health care nurses' attitude and knowledge regarding the palliative care. It was interesting. We did a very comprehensive research. We found most of the literature was conducted outside the U.S., like Japan and some European countries. So we are surprised because palliative care is a kind of idea. It's not already. I would not say it's originated from U.S., but we are surprised to say there's so little research has been done in the U.S. in this field. Do you think? Do you have any comment on this? Is maybe like some policy or like reimbursement may related to this lack of evidence?
Yeah, of the specifically around the community-based component of palliative care.
Yeah.
Piece of it. I think, I would say it's probably because here, one, palliative care is a pretty new field, even though, a lot has happened. But if you think about its origins in the U.S., hospice developed as very community-based. In fact, the early hospices were specifically outside of the sort of medical establishment. So you sort of had that things happening in hospice. Palliative care in the U.S. really had its origins as being hospital-based and actually academic hospital-based. And so I think we haven't had the connecting of the two. I think, some of it, of course, is payment structure based, as hospice is a defined benefit with services and a relatively limited population because of the way the hospice benefit in the U.S. is defined. And palliative care in the hospital had been, mostly supported by hospitals and now professional billing. And we still don't have a great funding source for true community-based palliative care. So I think it's probably a combination of how palliative care had its origins as a field in the U.S. plus some of the funding structures. I do think that we're seeing increased interest in true community-based palliative care, and some of it has to do with value-based contracting and the recognition that we actually need to be looking at care for our population across wherever they are. And in fact, most people spend fortunately or hopefully very little of their time within the four walls, especially of our academic hospitals. So I think it's a great topic area to be focusing on.
Thank you.
Well, thank you. So any last questions, thoughts from anybody? Jean, I just thank you so much. It's been over a year. You were scheduled back pre-pandemic.
Oh my gosh, I forgot about that. That's right. It was April 20 something or another of 2020. You're right. And
Yeah.
oh, it'll still happen. It'll still no.
Yeah, but so we got Jean back here. We do want to say that we do have another workshop. So our next event is going to be May 6th. It's going to be a 2-hour event, which is also going to be about building the next generation of palliative nurse researchers and clinicians. And Felicia Knoll and Billy Rosa will each be presenting. And then we had a poster competition, and Betty Farrell will be moderating our poster presenters that won. So I just want to thank you, Jean, again, and thank you for all your wisdom and help as we're trying to get CPC off the ground. The PCRC has been very helpful, and you've been very helpful on our advisory board. So thanks again, and thanks everybody for coming.
My pleasure. Thank you all.
Bye-bye.